Hi, my name is Walter Chan. I'm the Director of Center for Gastrointestinal Motility at Brigham and Women's Hospital. Today, I'll be talking about comprehensive approach to eosinophilic esophagitis. Just a little background on EOE. This is a clinical pathologic diagnosis. EOE should be clinically characterized by symptoms related to esophageal dysfunction. And pathologically, there should be at least one biopsy specimen that show eosinophil predominant inflammation. Currently, this is described and defined as at least 15 eosinophils per high power field on esophageal biopsies. The disease should be isolated to the esophagus, and other causes of esophageal eosinophilia should be excluded. The incidence of EOE has been increasing, and research have shown that this is likely a true increase in disease incidence rather than providers paying more attention to the disease. There's been a prospective population study in Switzerland where 2 gastroenterologists and 1 pathology center used the same criteria for EOE for 14 years. And what they found was a significant increase in incidence of EOE diagnosis as well as prevalence of the disease over time. Currently, the incidence is estimated to be about 3.7 per 100,000 patient years, with a prevalence of about 22 per 100,000 patient years. EOE is diagnosed in both adults and children, although there's a clear male predominant of at least 3 to 1. The most common age group where EOE is diagnosed is from childhood to about 2nd to 4th decade of life, with a mean age of about 37 years. The symptom duration prior to diagnosis, it's on average 4.5 years. So many patients may experience symptoms before they come in to seek care or being diagnosed with the condition. There have been some the EOE has been documented in most racial and ethnic groups, although it has been disproportionately shown in non-Hispanic whites. There's also some thoughts and data that have shown that there may be a possible regional or seasonal variation in EOE. For example, in the US, there seems to be a high prevalence of EOE in the Northeast. And there might be more severe symptoms that have been reported among patients during warmer months, usually corresponding to an allergy season. EOE is believed to be an immunologic condition. The esophagus is normally devoid of any eosinophils, and the infiltration of eosinophils suggests an immunologic mechanism of the condition. The current pathogenic pathway has been shown to be Th2 inflammatory response to an antigen or a trigger, which lead to cytokine release, including IL-5 and IL-13 production. These would then trigger eotaxin-3 production, leading to recruitment of eosinophils to the esophagus. There also appears to be a possible genetic predisposition to EOE. About 7% of children with EOE had a positive family history of the condition. About 10% of EOE patients with stricture have been found to have parents with EOE. And there appears to be a 50-fold sibling risk ratio. About 3% of patients with EOE have siblings with EOE as well. There are some proposed genetic defects that have been suggested, including a possible susceptibility locus on the chromosome 5q22. There are also some variations in TGF receptors and genes, as well as filaggrin genes that have been suggested. Some eotaxin-3 gene polymorphism has also been suggested to be related to EOE. EOE molecular transcriptome studies has also identified individual genes that may be associated with EOE as well. There appears to be an environmental factor related to EOE as well. EOE has been strongly associated with atopy, where up to 86% of adults and up to 93% of children in prior study having been shown to have concomitant atopic conditions. The recruitment of eosinophils to the esophagus may also be an immune response to environmental allergens. There's some evidence of seasonal variation in EOE, where there's an increase in incidence of diagnosis during the warmer months. There have also been geographic variations that have been identified, including increase in incidence in lower density and rural areas. Perhaps these are related to an increase in environmental allergen exposure, leading to EOE. There appear to be some differences among adults and children who are diagnosed with EOE as well. For example, among adults, this appeared to be predominantly environmental allergen driven, the most common being grass and pollen, with others including aspergillus, house dust mites, and cockroaches. Food allergen also plays a role, and oftentimes these allergens are diagnosed by skin prick tests or an increase in IgE specific to specific food or environmental allergens. In children, the conditions appear to be predominantly food allergen driven, including milk, wheat, egg, and soy being the most common allergens. There are occasional aeroallergens have been identified among children as well that might be related to the EOE, including grass, cockroaches, and house mite allergens. It is also important that there are other causes of esophageal eosinophilia, including gastroesophageal reflux disease, eosinophilic gastroenteritis, inflammatory bowel disease, infection, hypereosinophilic syndrome, achalasia, drug hypersensitivity, different vasculitides, connective tissue disease, or graft versus host disease. Therefore, it is important to take these conditions into consideration and evaluate for them when EOE is suspected or identified. The clinical presentation of EOE includes mainly esophageal symptoms, the most common of which are dysphagia. About 15% of patients who undergo upper endoscopy for dysphagia have been shown to have EOE. Other common symptoms associated with the conditions include heartburn and chest pain. A lot of these patients also have a history of allergic conditions, with an atopic history up to 74%. The most common conditions being asthma and dermatitis. Up to 69% of patients have also been identified with food allergy. But the important thing to remember is that many patients may not have been tested for these conditions or may not report these allergic conditions even if they have them. Therefore, EOE should be suspected even in patients who have no underlying or known allergic or atopic condition. Food infection is also a common clinical presentation for EOE. In fact, EOE has been found in up to 55% of adults presenting with food infection, and up to 55% of EOE patients may experience food infection as well. Some of the independent positive predictors for food infection has been identified include esophageal rings, erosive changes, and eosinophil density and biopsies. A study had been done on EOE patients looking at their natural history, and it's been found that a delay in diagnosis was associated with an increase in fibrostenotic features found on endoscopy. And the prevalence of esophageal stricture also increased with the duration of diagnostic and treatment delay. This is important as many patients may experience EOE symptoms prior to diagnosis, and it appears that the longer they wait, the longer the delay, the more likely there might be fibrostenosis in the esophagus at the time of diagnosis. And this brings us to a natural history of EOE, where we believe now that EOE goes through a process where you start with mainly inflammatory changes, followed by remodeling and fibrosis of the esophagus, ultimately leading to significant fibrostenotic changes. Symptoms are more closely associated with esophageal remodeling than degree of mucosal inflammation. Therefore, given this natural history, early diagnosis and treatment, including maintenance therapy and frequent monitoring, may help prevent these fibrostenotic changes and stricture development. And this is one important goal of the management of EOE, is to prevent progression of disease and progression to fibrosis. How do we diagnose EOE? On endoscopy, there are a number of characteristic signs that you may look for, including active inflammation such as edema. You may see a decrease in vascular markings in patients with EOE. There might also be whitish exudates or lesions that might be seen on the esophageal surface. Longitudinal furrows is another common sign that you might see on endoscopy for patients with EOE. There are also some more chronic changes of fibrotic changes, including fixed esophageal rings. These might cause a trachealization appearance. There may also be more transient esophageal rings that might give you these felinization of feline folds. Strictures may also be present. Mucosal fragility, including these crepe paper mucosa, where you can see EC tearing of the mucosa, especially if scope intubation, may also be seen in patients with EOE. A scoring system for endoscopic findings for EOE has also been developed called the ERAF score. This takes into account both active and chronic changes that might be found on endoscopy in patients with EOE. Including edema, rings, exudate, furrows, and stricture. This allows a standardized scoring system that can be documented both at time of index and follow-up endoscopy to allow assessment of changes over time and responsive therapy. The ERAF score should be used on the highest scoring segment of the esophagus. One question for diagnosis of EOE is how many biopsies should be taken and at which locations. There have been studies looking at this, including one of over 100 patients with over 1,300 biopsy fragments. It was found that diagnostic yield become adequately high at about four segments. So there should be the minimum number of biopsies to be taken during endoscopy. It was also shown that there's no increase in diagnostic yield beyond taking 6 fragments of biopsies during endoscopy. So the current recommendation is to take 4 to 6 total biopsies on both the distal and proximal locations to ensure adequate sensitivity in the diagnosis of EOE. There might be different patterns and distribution of eosinophilia among patients with EOE, as the involvement of eosinophils in the esophagus may be patchy. This is a study that we did where we looked at the distribution of eosinophilia among patients who had 2 biopsies taken from 2 different sites in the esophagus. And it was shown that a significant proportion of patients may have either proximal or distal only involvement of eosinophilia. So it is important that biopsies to be taken in both proximal and distal sites in patients with suspected EOE. So what are some diagnostic criteria for EOE? A patient needs to have symptoms of esophageal dysfunction. Some of them may have concomitant atopic condition, which may raise suspicion for EOE. There may also be endoscopic findings that may raise suspicion for EOE, including rings, furrows, edema, stricture, narrowing, and crepe paper mucosa that we talked about. However, they may also not always be present or be obvious. On histology, there should be at least 15 eosinophils per high-power field on esophageal biopsies. And eosinophilic infiltration should be isolated to the esophagus. Non-EOE disorders that may cause or potentially contribute to esophageal eosinophilic should also be assessed. So what are the treatment of EOE after we talk about the diagnosis? There's the 3 Ds that we often think about, which are drugs, diet, and dilation. Among drugs, there's several different treatment options include proton pump inhibitors, steroid immunomodulators. Diet includes various forms of elimination diet. Both drugs and diet mainly target active inflammation. Dilation is mainly for treatment of fibrostenotic disease and strictures in the esophagus. So the first one we'll talk about is one of the drugs, which is PPI. PPI has been shown to lead to remission of EOE in some patients. There are a few possible mechanisms that have been speculated, include possible reduction in reflux, as we know GERD may contribute to esophageal eosinophilia. PPI may also improve mucosal integrity, which may decrease exposure to potential environmental food triggers. There have also been some studies that have shown that there may be a direct anti-inflammatory effects by PPI. The response for PPI has been reported to be around 50% for histologic remission and about 60% for symptom improvement. The challenge of the use of PPI is that both PPI responsive and non-responsive EOE appear very clinically similar. There are some potential factors that have been associated with PPI response or non-response, such as the presence of esophageal rings, increase in peripheral eosinophils, which have been associated with non-response, and a history of atopic conditions, which has also been associated with PPI non-response. The dosing and regimen of PPI in the treatment of EOE is also important. There's a study that we published looking at different regimen of PPI in inducing response in patients with EOE. What we found was that twice daily dosing is associated with significantly higher treatment response compared to once daily dosing of PPI. Importantly, twice daily dosing with a moderate dose, in this case we use omeprazole 200 grams twice daily, had similar response rate compared to higher dose of twice daily dosing, which in this case was omeprazole 40 milligrams twice daily. So the key thing here is that it is important to ensure that we use twice daily dosing in inducing treatment response to EOE. How about maintenance regimen? This is still a little bit unclear. There have been one study looking at PPI responsive EOE patients where the PPI dose was tapered to the lowest dose for maintenance. In this study, about 73% of the patient has sustained remission after 1 year of PPI tapering. So tapering dosage appears to work in some patients for maintenance. There were some predictors of relapse that have been suggested, such as rapid metabolizer for PPI. However, given that a majority of patients were able to remain in sustained remission after tapering the PPI dose, it would be reasonable to taper PPI to the lowest dose possible. The important thing is that they should be followed up by a biopsy to ensure that they remain in histologic remission after you taper the PPI. So what I usually do is that I would taper patients' PPI to a lower dose, and after about 8 to 12 weeks, I will repeat an upper endoscopy with biopsies to ensure that they remain in remission. Next, we're going to talk about steroid therapy. This mainly involves the use of topical steroids. Steroids have been shown to induce remission and reduce esophageal remodeling among EOE patients. The type and dosing of steroid really depend on the severity of inflammation, patient tolerances, and their resources. The treatment response has been shown to be dose dependent, although not really drug dependent. Symptoms often recur if these steroids discontinue, so maintenance therapy is important. It is important to set the correct expectation with the patients that once they're started medications, they really should continue them for maintenance therapy. You may consider dose de-escalation with ongoing monitoring once remission is achieved or achieved for a long time. So what I do with a lot of my patients is that if they achieve histologic and symptomatic remission and they continue to do well, I may consider tapering their dose, but it is important to remember to do a repeat biopsy with repeat endoscopy with biopsy to make sure that they remain in remission if you're going to taper the dosage. The couple different formulations for steroids include budesonide and fluticasone at doses that you can see here. The advantage of the use of steroid therapy is that they're really fast in inducing an effective response. However, patient really need to pay attention to the method of administration, really to ensure adequate contact between the steroids and the esophagus. A treatment response rate in clinical trial has been estimated to be about 50 to 70% with the use of these topical steroid formulations. This is a summary of some of the current data that we have on the use of the different formulation of steroids for inducing treatment response. And as you can see here, is usually ranging somewhere around 60 to 80% being the treatment response rate for steroid therapy. They've also been studied comparing the two formulations of topical steroids. In one study, 75 EOE patients treated with fluticasone and budesonide were compared, and there was no significant difference in treatment response histologically that were discovered between these two groups. There's also another study looking at potential predictors of treatment response on non-response to steroids. And non-response was found to be associated with patients who have esophageal narrowing that require dilation on baseline endoscopy. This is not surprising, as these group of patients may represent those who already have fibrostenotic changes that are less likely to respond to anti-inflammatory therapy. Response has also been associated with pain-predominant symptoms. One potential limitation for the use of steroid therapy is potential long-term adverse effects, especially given the need for maintenance therapy. These topical steroid therapy has been associated with thrush, esophageal candidiasis. There are some concerns about adrenal suppression, although up to 2 months of treatment, no evidence of adrenal suppression had been identified. There are no other long-term safety reports associated with topical steroid therapies for EOE for either growth or bone density. However, given the need for maintenance therapy, we talked about the dose de-escalation previously. There have been a trial looking at dose de-escalation of EOE patients. This one had 28 EOE patients treated initially with fluticasone 1760 microgram daily for 3 months, followed by a tapering to 880 microgram daily for 3 months among the responders. And what was found was that overall, the higher dose of fluticasone induced about remission rate about 65%. And after dose was tapered to the 880 microgram doses, about 73% among those who responded initially remained in remission. A newer class of treatment approved for EOE are immunomodulators with dupilumab. Dupilumab is a monoclonal antibody which inhibits IL-4 receptor alpha, leading to anti-IL-4 and IL-13 activities. There have been clinical trials comparing different dosage of dupilumab because this has been used with different doses among patients with other atopic conditions. And in this phase 3 trial, we compare dupilumab at 300 milligram weekly dosing to every other week dosing to placebo in EOE patients. It was found that for histologic remission, both weekly and every other week dosing were found to be to induce significantly higher rate of remission compared to those treated with placebo. However, when looking at change in dysphagia symptoms from baseline, those who were treated with weekly dosing had more significant improvement in symptoms, while those on every other week dosing did not achieve significant improvement in symptoms compared to those on placebo. That is why the current recommended dosage for dupilumab for EOE is a weekly dosing. There are some adverse events that have been reported, including injection site reaction, development of antibodies to the dupilumab, conjunctivitis, myalgias, and facial redness. Dietary therapy is another approach. It's the only non-pharmacologic approach for active inflammation for EOE. The goal is to eliminate potential trigger for inflammation in these patients. The problem with dietary therapies is often challenging to identify the culprit allergens that might be leading to symptoms. There are also some concerns for costs related to following this therapy, as well as patient adherence, as it can be quite challenging and quite limited. Relapse of EOE is common among patients following dietary therapy, given how restricted they can be. When you look at the most common triggers for EOE, milk and wheat appear to be most common allergen triggers. Interestingly, foods that often induce anaphylaxis, like peanuts or shellfish, really rarely cause EOE. And there are a few dietary therapy strategies that have been looked at. One is by using an elemental diet. these are usually amino acid-based formulas. They are shown to be most effective as they're devoid of almost all potential allergens. The disadvantage that they are usually costly and they're very difficult to adhere to because this will significantly impact the quality of life, as patients can basically only stay on these very restricted elemental formulas. The response rate, not surprisingly, is high at around 90% with the use of elemental diet. Targeted elimination involve eliminating potential food based on allergy testing, either a skin prick testing or an atopy patch testing. This can really simplify the regimen for the patients because they really only need to eliminate those for which they test positive. The problem is that patients often test negative on routine skin testing for food allergens. So a lot of times you may not be able to identify a target to eliminate. So in clinical studies, the response rate to targeted elimination is really only about 46%. Finally, the most common one that we currently use are empiric elimination. This may most commonly involve elimination of 4 or 6 foods from the diet. This usually involves a standardized approach where specific food or food groups are being eliminated and reintroduced sequentially in a standardized manner. Usually the advantage that no testing is required. You basically just empirically eliminate these food groups. The disadvantage that they can still be burdensome because there's still a lot of food that patients might need to eliminate. And this also requires multiple endoscopy to assess response as you reintroduce food items, so they can also become cumbersome and challenging. Safe food elimination diet has been found to have a response rate around 70%. There's a more simplified 4-food elimination model with a lower response rate to about 54%. Let's go a little more into the elemental diet. There's some early evidence in children that food allergens may trigger EOE. And it's been shown that if you place patients on an elemental diet, over 90% will have resolution of their eosinophilia. Most of these are, as we said, amino acid-based formula. And the idea is that you should put these patients on elemental diet, and after 4 to 6 weeks of diet, you introduce food one by one to look at the response. There have been a study looking at 18 patients, adult patients with EOE who were treated with an elemental diet. The histological response rate is about 72% after about 2 to 4 weeks being on this diet. However, after resumption of a normal diet, the eosinophils increase in 3 to 7 days after. What about 6-food elimination diet? This involved the empiric elimination of common culprits of immediate hypersensitivity without the need for or basing it on allergy testing. These 6 food groups include milk, wheat, egg, soy, tree nuts or peanuts, and fish or shellfish. The most common allergen in children are usually milk, with the second one being wheat. Interestingly, for adults, this tend to be reversed, where the most common allergens are wheat, more so than milk. The 4-food elimination diet is a little bit more simplified, where tree nuts and peanuts and fish and shellfish were not included. So you really only do the first 4, which are milk, wheat, egg, and soy as a primary group. Now, how do you reintroduce in the elimination diet? Generally, you want to reintroduce from the least allergenic to most allergenic food. And if patient symptoms recur as you reintroduce, you should then tell the patient to avoid that trigger food and replace that with another one within the same group before you go back and take repeat biopsies. An alternative approach is to introduce several foods at once from the same food group in the hope that you may decrease the number of endoscopies required to complete the elimination diet. If we talk about the 4-food elimination diet, mainly involve milk, egg, wheat, and legumes. Once remission is achieved, again, reintroduction trials should go from the least to the most allergenic. The response rate of 4-food elimination diets be about 50 to 60%. The most common culprit, again, is milk, followed by egg, followed by wheat, and lastly, legumes. If patients do not respond to full food elimination diet, about 31% of the non-responders may achieve remission if there is then switched to the 6-food elimination diet. This is a summary of what we currently know about the different dietary therapy. Overall, the treatment effect has been estimated to be about 66%, with the highest being the elimination diet around 90%. An allergen testing directed elimination diet has about 45% overall effect. The two main empiric elimination diet, including 4-food and 6-food elimination diet, a response rate of about 60%, 50 to 60% for 4-food elimination diet, and about 70 to 80% for 6-food elimination diet. There are a number of other dietary interventions that have been suggested, including a gluten-free diet, which has shown to have an overall effect of about 58%, potentially milk elimination diet based on patient's history, and overall treatment effect with the milk elimination diet is about 68%. So the overall strategy for dietary therapy is that you eliminate, followed by stepwise reintroduction. It is important to take into account a patient's overall nutritional intake to make sure that they're getting in adequate calories. This is where it is important to work with an experienced nutritionist, both to counsel the patients regarding the therapy and also to make sure that they're having adequate nutritional intake. You have to take into account the cost and potential impact on the patient's quality of life because these elemental and other diets may be expensive. And a lot of times they may not taste good, which may also cause a lot of non-compliance or negative impact on the patient's quality of life. It's important to also remember that this strategy requires multiple endoscopies to assess response. So this is something to discuss with the patient prior to initiating a dietary therapy. The last treatment option or last D that we're going to discuss is endoscopic dilation. This is mainly for treatment of fibrostenotic disease of EOE. There have been some early reports of higher rates of perforation and chest pain after doing endoscopic dilation in EOE patients. This has led to some early guidelines suggesting avoiding endoscopic dilation until you have either treated these EOE patients with medical or dietary therapy. However, since then, there have been multiple studies that have been published in patients with EOE undergoing dilation. And these have shown an overall relief of dysphagia of about 91%, with a mean duration of symptom control about 22 months. The important thing is that among these studies, complications were infrequent. There were only a total of 3 mucosal tears, with 2 requiring a short hospitalization for pain. But overall, there were no perforation episodes that were reported. So the more recent international guidelines for EOE suggest that for high-grade strictures, dilation before initiation of medical therapy has been shown to be well tolerated and effective. And in a more recent study, looking at over 500 EOE patients where over 160 required dilation, a total of about 480 times, some of the predictors have been identified for the need for dilation include a longer duration of symptoms before diagnosis. Importantly, 58% of patients require more than 1 dilation, and some predictors for needing repeat dilation include a smaller baseline soft jaw diameter. Overall, the complication rate is about 5%, primarily with post-procedural chest pain, and there were no major bleeding, perforation, or death associated with dilation among this larger group of patients. How do we perform this dilation? First of all, the dilation goal is around a soft jaw diameter of about 16 millimeter. The key is to start low and gradually increase your size of dilation. However, it is not recommended to have a more than 3 millimeter in progression in diameter per session. So you can slowly increase the size, but I wouldn't go more than a 3 millimeter increase total each time you dilate. Overall, there's no difference in safety and efficacy between the use of bougie dilation and the through-the-scope balloon dilators. This decision can be based on the location of the stricture, the length of the stricture, the soft diameter, expertise, and availability of equipment. Post-dilation pain is common, so really counseling the patient before and after the procedure is important. A lot of times patients may need repeat dilation periodically if their symptoms recur. So how do you choose between drugs, diet, or dilation strategies for treating EOE? PPI is overall effective with an efficacy of 50%. It's easy to use, although a lot of times patients might be concerned about potential long-term effect of PPI use despite data not substantiating them. For steroids, there's an overall efficacy of about 50 to 70%. They're rapidly effective, although it may be associated with some steroid side effects. Diet has an overall efficacy of about 66%, ranging from 60%, about 60% for full elimination diet to about 80% for 6 food, up to 90% or so for elemental diet. The advantage is that this is non-pharmacologic, so you can avoid side effects, and also for patients who do not want to take medications, this might be their treatment of choice. However, diet often can be costly, and there can be significant impact on patients' quality of life. And a lot of times they also need multiple endoscopies to assess response to different changes in elimination and reintroduction of dietary items. Dilation has an overall efficacy of about 90%. It's rapid with an effective treatment response, although it can also be associated with some procedural risk as well as post-procedural pain. The indication of treatment is important too in terms of deciding which treatment to choose. As we mentioned, PPI, steroid, immunomodulators, and diet are all targeting active inflammation, while dilation is mainly for fibrostenotic disease. There are also some therapies in the pipeline, mainly involving different immunomodulators. We know dupilumab is currently available, but there are also other ones that target other parts of the pathogenic pathway for EOE. So in summary, EOE is a chronic inflammatory condition that are likely associated with either environmental or food allergens. EOE is most commonly diagnosed in men, Caucasians, and those in the second to fourth decades of life. Dysphagia and food infection are the most common symptoms and complications. Characteristic endoscopic findings for EOE may include rings, longitudinal furrows, edema, whitish exudates, narrow caliper esophagus, and crepe paper mucosa. Diagnosis of esophageal eosinophilia requires esophageal mucosal biopsies that show at least 15 eosinophils per high-power field. About half of the patients with EOE may demonstrate clinical and histological response to PPI. And the therapeutic options for EOE may include drugs, which include PPI, steroids, and dupilumab, elimination diet for active inflammation, as well as endoscopic dilation for fibrostenotic disease. Dietary therapy for EOE in the order of efficacy include elemental diet about 90%, 6-foot elimination diet at about 80%, 4-foot elimination diet at about 60%, and maybe also allergen testing or allergy testing directed elimination, which ranged about 40 to 50%. Treatment of active inflammation of EOE requires maintenance therapy, regardless of which modality you choose, whether it's PPI or steroids or dupilumab. Endoscopic dilation is safe and should aim for an esophageal diameter of between 16 to 18 millimeter. So this is the management algorithm that's currently suggested for treatment for EOE. At the top, you have different pharmacologic therapy, including PPI, steroids, and elimination diet. A newer one that's now available is dupilumab. Endoscopic dilation is mostly used for those with evidence of fibrostenotic disease. Importantly, long-term treatment with an effective anti-inflammatory drug or diet is always needed for maintenance therapy. Thank you.